Hello, my name is Ben Cray-Brown. I'm one of the chief investigators of the SQUEEZE study together with Ibjama from Bergen in Norway. And the history of this study is that we came up with this idea and we proposed it to ESAIC, or ESA as it was then, the European Society of Anesthesiology, and they agreed to fund it for us back in 2018. And because of delays of COVID, things haven't run as quick as we had anticipated, but nonetheless, we have recruited more than 15,000 participants from more than 150 centres from more than 40 countries. And I've made this slide set in preparation for the UK joining this international effort. So using what we've learned from other countries' experiences, I'm going to go through some of the common problems and explain how we can overcome them. So the first thing to talk about is the confusion that can stem from having two different cohorts and in fact in the UK's case, three different case report forms. The simplest kind of observational cohort study would have just one cohort. We've made it slightly more complicated to have two cohorts, and I'll explain why. We're interested in post-operative vasopressin infusions, or PVI. It's a sort of an abbreviation we've made up, but it's useful because we talk about it, PVI, a lot. And to find out determinants of PVI, you need a cohort where some people have it and some people don't have it. And because post-operative vasopressin infusions aren't that common, we need to have quite a lot of patients to look at those who don't have it, as well as those who do have it, to work out factors associated with PVI. So that's the purpose of Cohort A. And to recruit Cohort A, you need to recruit or collect data on a large number of patients in a short period of time. So we're proposing a busy week, where we collect a lot of patient information. And we anticipate only a minority of patients will have PVI. But we also want a lot more information about patients with PVI, and we know there's going to be a range of severity of illness. So some patients will have a low dose of vasopressin infusion for a few hours after their surgery. Others will be on multiple different vasopressors for days after the surgery. And to get a lot of information, or at least a little bit of information about all the different types of PVI and all the different types of surgery, we need more patients with PVI. So the way to do that is a second cohort of patients who collected over the course of the rest of the year. Initially, we were going to have Cohort A collected by each centre and then Cohort B following that, but actually it doesn't matter. So you can do Cohort A for a week within the year, and Cohort B is the rest of the year. And in terms of the data we collect about them, so every patient in the study has the main information about them and their surgery and their outcome. That's CRF1, Case Report Form 1. If they additionally have post-operative vasopressin infusions as part of Cohort A or Cohort B, then they have this additional information collected in CRF2. One of the main differentiating factors between the UK implementation of SQUEEZE and the international is we're collecting data on atrial fibrillation, and that will be in CRF3. So this is a diagram I made which meant to make it a little bit clearer. So the busy week, Cohort A, most people are blue, which means they don't have post-operative vasopressin infusions. Some patients will have post-operative vasopressin infusions, and they're in red here. Some will have post-operative vasopressin infusions and atrial fibrillation, and they're in yellow. And some will just have AF, and they're in green. So if you just no post-operative vasopressin infusion, you're blue. If you have post-operative vasopressin infusion, you're blue and red. Sorry, you complete 1 and 2. If you have atrial fibrillation, it could be 1 and 3, and if you are a patient who's had post-op vasopressin infusion and post-op AF, you have 1, 2, and 3. That's during Cohort A. Cohort B, all the patients have post-op vasopressin infusions. That's why they're in Cohort B. So they all have 1 and 2, but again, for the UK, some of them will also have AF, so they have 1, 2, and 3. I hope that makes it a bit clearer. You might say, we're not used to this abbreviation PVI. What does it actually mean? Well, we're interested in people who are on drugs that are predominantly vasopressors. We don't want repeat boluses, it has to be an infusion. And we're not really so interested about the people who've had intraoperative vasopressors that then subside very quickly. We're also not interested in people on vasopressors for more than 24 hours after surgery. That's a whole different kettle of fish. And we're also not interested if they're on, well, we're not going to exclude people who are on vasopressors that start before their surgery. That you might have patients who come from your ICU on vasopressors, go to theatre, come back. So we still want information about them, so long as they have post-op vasopressin infusions. So I made a diagram to help make that clearer. So the orange is the duration, or when they're on a vasopressin infusion, and this is when they have their surgery, and this is the time after their surgery. So if they're on their infusion during their surgery and for hours after their surgery, then yes, that's PVI. If they're on it during, after, and still for more than 24 hours, yes, that's PVI. If they're not on it intraoperatively, but for whatever reason after their surgery they go on it and it stops within 24 hours, yes, I'm interested in that. If they start on it post-operatively and it carries on, yes, I'm interested in that. If they're on it intraoperatively, post-operatively, and later, yes. But if they only start late, not interested. If they only have it intraoperatively, not interested. So hopefully that'll be a bit clearer. What kinds of patient are we recruiting for all cohorts? Well, we don't want minor surgery, day case surgery. But having said that, if someone's having day case surgery and end up staying, then they can be included. If they have an unusual type of surgery, cardiac, transplant, obstetric, they're excluded. We're not interested in them. If they're unusual types of patients are not representative, and they might have some reasons why they behave differently, so they might be on long-term infusions of vasoactive drugs, perhaps they have pulmonary hypertension, perhaps they have LVADs. I mean, these are unusual things, but we would not want to include them. If they're having a regional anaesthetic only, yes, we will include them, so long as they're not day case. If they're local only, probably they're going to be day case, so probably we're not interested in collecting data on that cohort. How many patients does your centre need to recruit? Well, it does depend on how many people you can find to help you recruit and how large and busy your hospital is. So in the busy week, we'd really like you to get as many as you can. And we would recommend you start running on a Tuesday morning because it gives you Monday to prepare, and you go all the way through till the following Monday just before the time you started the previous Tuesday. And that does include a weekend. And it may be tricky to get people to recruit over the weekend, but if you could try, that'd be great. You can collect a lot of the data on the day, sorry, a little bit of the data on the day and the rest of it later, so that might help. We're thinking in the region of about 100 patients would be what we're expecting. But that's not a target, it's not a minimum, that's just roughly what we're expecting. For cohort B, this is one of the things, is that the use of post-op vasopressor infusions varies a lot according to hospitals and culture and practice and what kind of patients you have. So it's difficult to know, but we hope that you capture about 30 patients over the whole year. Will you be an author on the final output? Well, yes, we'll do our best. The idea is that we want to be inclusive, include everybody who's helped us to collect this data. Having said that, the rules on authorship do vary between the journals. So if you look at similar studies published, so ESOS is quite similar to this in the sense it's a perioperative European or international collaboration, and that was published in the Lancet with 2,000 authors. But later, ISOS, which has other similarities to this, was published in the BJA, and there was a group name as the author, and then 2,000 people were collaborators. So we have a detailed authorship policy that you can get from the website, which is hosted by ESAIC. And the other thing to say is we're not giving specific numbers, like you have to get a certain minimum to be counted, because people that tends to be treated as a target rather than a minimum. So we'll see how many you recruit, and we'll have a talk to you and bear in mind whatever factors come into play. One thing that has been confusing for people, not so much about the protocol, but about the case report form, whether people should tick the box for TIVA or volatile. Now, I'm not an anaesthetist, but I can explain this to you, that we're interested in how anaesthesia is maintained, not induced. So here's a little table. If they have IV induction maintained volatile, I'd like you to click volatile. If they have IV all the way through, that's clearly TIVA. If they have volatile all through, that's clearly volatile. If they have IV and then attempt at TIVA and then a change to volatile, which I understand sometimes happens, then you click TIVA and volatile. The common problem is that people are being induced with IV and people completing the CR for ticking TIVA and volatile, and that's not our intention. So thank you very much for listening. I hope this has been useful. I want to thank the UK Study Steering Committee and the SQUE and everyone helping deliver this across the UK. It's going to be a huge amount of work, and I'm really grateful. ESAIC hosted a UK specific email address that's answered by the UK study team. So if you've got any other questions, have a look on the website and perhaps email this email address for further help. Thank you very much.